Welcome, everyone. We are excited to be having you here with us. My name is Aisha M. Wilson, and I am a member of the Greater Boston Association of Black Social Workers. And we are excited to bring to you today an opportunity to talk about social work cares about prostate health in collaboration with AdMeTech. As a member of the Greater Boston Association, our mission and work has been organized since 1968 as one of the founding chapters of the National Association of Black Social Workers, the NABSW. As a local affiliate of NABSW, we advocate for social change, justice, and human development of African people in the United States and throughout the world. The Greater Boston ABSW is comprised of social work students, young professionals, and seasoned practitioners of African ancestry who continue the struggle for justice and freedom. In addition to persistently pursuing the elevation of Black people, the Greater Boston ABSW provides intensive training through various workshops, seminars, and conferences. By sharing knowledge, we improve services to those we aid. We aim to promote our community's welfare, survival, and liberation, as well as advocate for social change at all levels of government. To emphasize the importance of the Greater Boston ABSW and our mission, again, we warmly welcome you to the Social Work Cares About Prostate Health in collaboration with AdMeTech. Now, as social workers, we know that the caring and the need of individuals who are suffering or may be going through the process of dealing with prostate cancer it's difficult. It is a difficult one. And we also recognize that their loved ones are also grappling with the difficulties as well. And so through that, this conversation not only talks about awareness, but it also talks about how to be cared for and caring as a loved one. Within the Greater National Association of Black Social Workers, our Code of Ethics, it states that I regard my primary obligation the welfare of the Black individual, the Black family, and the Black community, and will engage in action in improving social work conditions. As social workers, our commitment to social justice is not limited. As a Black social worker, we call on our communities to uplift each other and to achieve the greatest outcomes for all of us. So, again, I thank you and I welcome you, and I want to make sure that I introduce our panelists. So we have Dr. Sean Wasson, who is a faculty member of the Division of Urology and Associated Physician of the Harvard Medical Faculty's Physicians, Milton Center for Specialty Care, and Needham Urology Associates, Beth Israel Deaconess Medical Center, Beth Israel Lahey Health, and Harvard Medical School. We also have Dr. Stern with us, who is the founder of the AdMeTech Foundation, and I am just grateful as a member also of NAACP, where we have partnered for many years on bringing more awareness throughout our communities throughout Greater Boston. So now I'd like to call on Dr. Watson to lead us in a presentation, and then we will have Dr. Stern, and then we'll open up for Q&A. Thank you. Dr. Watson?
Thank you so much for the kind introduction. Appreciate it. And thank you all for the invite today. I'll just share my screen. So today I want to go over some of the advances in the diagnosis of prostate cancer and what we do in our practice. As Aisha mentioned, I'm a faculty member in the Division of Urology at Harvard Medical Faculty Physician, part of Beth Israel Lahey Health. I work at primarily in Milton Hospital, and we have an outpatient department. So today I want to go over some of the sort of, some of the higher level kind of latest advances in prostate cancer diagnosis. And I think that there's really three modern pillars. Number one is individualized screening. In an era where we used to go to churches on the weekend and we would do mass screenings on men, try to identify prostate cancer, that's no longer the case. And really, we really want individualized screening for men after going over shared decision making. We really want to have aggressive equity. So, we do know that, Black men have higher, risk of prostate cancer and dying from prostate cancer. And what are the ways that we can equalize the treatment for, men in our society? And then what are the sort of like some of the precision diagnostics that we're using to make the diagnosis of prostate cancer? And we'll go over the use of multiparametric MRI and biomarkers to make that diagnosis. So routine screening for everybody presents a delicate balance between the modest mortality benefit of finding prostate cancer and significant patient harm. We know that finding prostate cancer typically involves a biopsy of the prostate, and we know that there's overdiagnosis in our society. And patients that are diagnosed with prostate cancer, face significant anxiety. And so we really want to minimize the diagnosis of low-grade prostate cancers and really focus in on the intermediate and high-grade prostate cancers. We know that biopsy itself leads to bleeding and infection, so we really want to minimize those complications. And we understand that prostate cancer itself really affects erections, erectile function and urinary incontinence. And so we only really want to treat the men that really need treatment. So we know that there is modest benefits in a lot of the literature showing that if you treat men for prostate cancer, it does take a lot of men to screen, and then you treat a certain subset of those men, in order to prevent death. So there's modest benefits for prostate cancer treatment. This is for all comers, and obviously there are higher risk groups that we'll talk about. There's really no major medical organization nowadays that currently recommends universal routine PSA screening in all men. PSA stands for prostate specific antigen. It's a blood test, easy to obtain, and really this is the first test that you want to do to screen men for prostate cancer. So there's the U.S. Preventive Services Task Force. The AUA is our society, the American Urological Society. There's the NCCN, which is National Comprehensive Cancer Network, and then the American Cancer Society. And these are all major organizations. And nowadays, we don't recommend routine screening for everybody. But what we do recommend is that there's shared decision making between a patient and their primary care provider. What is your sort of risk of dying of other diseases? Do you have at least a 10-year life expectancy? What are other sort of major medical comorbidities? And then what is your risk tolerance and patient values? And once we decide who to screen, then certainly that patient should go on to get a PSA blood test and then a digital rectal exam. Most of the societies say that a digital rectal exam is no longer recommended as a standalone screening test. Usually this is done in combination. And I went to Howard University for medical school, and Dr. LaSalle Lafall Jr., MD, he was, a prominent oncologic surgeon at Howard University. And I remember him being on the wards, and there'd be a group of medical students around him. And he said, the only reason not to perform a rectal exam is if you don't have a finger. And this really stuck out, to me. And every time I'm with a patient and we're discussing, prostate cancer screening and prostate cancer, I always do a rectal exam. And I can probably count on my hand the number of men, very small number of men that have been diagnosed with prostate cancer just based on the digital rectal, exam alone. Certainly, there are some patients with high-grade disease where the PSA will be normal, but clearly they'll have an abnormal digital rectal exam. So, I really encourage, men, your brothers, uncles, grandfathers to, push their primary care doctors to perform a digital rectal exam. Nowadays, I think it's fallen by the wayside, but you can pick up rectal cancers, you can pick up prostate cancer. And I would say, try to be an advocate for your patients. Dr. LaSalle Lafall, phenomenal urologic oncologist. He died in 2019 at the age of 89. He was appointed by two different U.S. presidents. He chaired the president's cancer panel. He was the first Black president of the American College of Surgeons and then the American Cancer Society. A lot of firsts. He was actually one of the youngest chairs in the Department of Surgery in all the country. Just a really remarkable human being and surgeon and person. These are the four different large, groups, and what do they recommend? And they're all a little bit different. So the U.S. Preventative Task Force, they say men in between the ages of 55 and 69 should get screened for prostate cancer. For those over the age of 70 and a little bit older that may have higher risk of dying from something else, they don't recommend routine screening in those particular men. The NCCN says for average risk patients, start at the age of 45, go up to about the age of 75 for routine screening. Men, though, that are, however, in the high risk category should actually start screening at the age of 40. If the PSA is really normal, you can extend that screening interval every 2 to 4 years. Clearly, if the PSA is a little bit higher, you want to screen them annually. Again, if you're over the age of 75, those are the men you don't necessarily want to do routine screening on. Our guidelines, the AUA, recommend for average risk men, 50 to 69 is the population that you want to target. But again, they do differentiate between the low and the high risk groups. And then the ACS, denotes high risk as being Black men, those having a first degree relative who is diagnosed with prostate cancer less than the age of 65. Those are the patients really you should start screening at the age of 45. So what we do know, Black men experience the most profound prostate cancer disparities of any race group in the United States, 1.8% time higher incidence of prostate cancer, higher mortality risk, almost 2 times, 1 in 6 lifetime risk of being diagnosed with prostate cancer, and then really presenting to us with advanced presentation. There's a variety of systemic and social, as well as biologic and genomic factors that may be contributing to this, higher rates of advanced diagnosis and death. These are, very common, very, very complex factors. But clearly there is a difference. However, when white and Black men with similar grade and stage receive equal treatment, they exhibit equivalent or superior outcomes. And, I think that this is important, especially for the work that Dr. Stern is doing with AdMeTech. How do we, treat everyone equally, make sure that everyone has access to the latest technology in terms of, diagnosis and treatments, and really level the playing field. So the first thing that we recommend is getting a PSA test. This is just a simple blood test, can be performed by the primary care provider. If it is abnormal, we recommend that patients repeat the blood test. We never go off on just one test alone. So we usually repeat it in a couple of weeks. You want to make sure that you've ruled out any other causes of an elevated PSA, such as BPH, benign non-cancerous enlargement of prostate gland, prostatitis, inflammation, recent ejaculation. If you've ejaculated within 72 hours, I tell patients to repeat that particular test. I always perform or recommend at least performing a digital rectal exam in conjunction with the PSA. And what you can do is you can say, okay, is there any tenderness? Is there any inflammation? Could this be prostatitis? What is the size? Are there any abnormal nodules? And put those two together. Those are typically done by the primary care provider. And then the primary care providers will typically send those patients to us to determine whether or not they need a biopsy. So primary care doctors are really the gatekeepers for the PSA, the shared decision-making discussion, and the urologists are really the gatekeepers for having those men undergo a biopsy. What's very one thing that we like to get is something called the PSA density. Not everyone is going to have a prostate size that is the same. Some may be small, some may be large. I'm actually more concerned about the men with very small prostates and very high PSA. So to calculate the PSA density, you need two things: an accurate measurement of the prostate size of the PSA. So if you have a PSA of 5 and a prostate size of 100 grams, which is very large, that particular density is going to be a lot lower than a PSA of 10 and a prostate volume of only 30. And so if there's any concern on the digital rectal exam or the repeat PSA, then those patients need to go on and get a multiparametric MRI. And we do this before the biopsy for a number of reasons. If you just went off that particular information, then most patients, in the past would go directly to perform a transrectal ultrasound guided biopsy. And I would say, in those particular cases, you may miss a higher grade lesion that's deep within the prostate. So if you perform the multiparametric MRI, you can determine, okay, is there any lesions within the prostate that may be harboring prostate cancer? What is the size of the prostate? And so you get a really accurate measurement of the prostate size. And we really want to diagnose, again, not the low-grade cancers, but the high-grade prostate cancers. The radiologist is able to give us a PI-RADS score, which is a score that goes from 1 to 5. And if there's any 4 or 5 lesions, then those are the lesions that have a high suspicion for prostate cancer. Those are the patients that need to go on and get an MRI guided biopsy. We really want to target those suspicious lesions that could be deep within the prostate. At our institution, we're exclusively using a multiparametric MRI. It's a 3 Tesla magnet. No longer do we need a transrectal probe. So patient literally goes into a scanner. It's usually about a 30 to 40 minute scan with IV contrast. It has a 99% sensitivity and a 60% specificity. There are some centers that are using biparametric MRI to make the scan a little quicker and without losing some of the detail. But for the most part, multiparametric MRI is recommended. There are certainly some cases that are in the gray zone where the prostate may be enlarged, the PSA may not be that high. This is a perfect situation before biopsy to risk stratify those patients. And before initial biopsy, there's multiple different biomarkers that we can use in practice. Some of these are blood tests, some of these are urine-based biomarkers to determine what is the patient's risk of having a clinically significant prostate cancer. And so we don't use all of these in practice, and depending on which provider you're going to see, they may use one, they may use multiple, but I think it's important in select cases to use biomarkers to really put in a category who are the ones at high risk, who are the ones that are not at high risk. For patients that have had a prostate biopsy that has been negative, there are also other biomarkers that can be used to determine, how frequently that patient needs to be screened moving forward. So we do both the transrectal ultrasound guided biopsy. This is typically done in our office with a ultrasound guided probe. We do look under ultrasound for specific lesions. So if you had an MRI that was negative, but you're still concerned about prostate cancer, you can do a templated fashion biopsy where you take 6 cores in the peripheral zone on both sides of the prostate. If you do have a lesion noted on MRI, notably, we still do the templated fashion biopsy. So we still take 6 on either side, so 12 in total, but we are passing the needle through the lesion about 3 or 4 times. So you can determine, is there prostate cancer within the other areas of the prostate, or is there any prostate cancer within that lesion that was noted on MRI. So this is called a fusion biopsy, where they can take the images from the MRI and fuse it in real time for the biopsy. So, number one, if you have someone who has a negative biopsy, what do we do in that particular situation? We're doing routine PSA monitoring, maybe every 6 months, every 12 months. We'll do a digital rectal exam once a year. We'll potentially use some of the biomarkers that are available. We will repeat a multiparametric MRI, and in some cases, we may recommend a repeat biopsy. So key takeaways, number one is we really have to individualize screening. Not everyone's going to get screened, but there are certain high-risk groups like Black men, patients with first-degree relatives, and some patients that have certain mutations like the BRCA1, BRCA2 mutation that should be screened at a very early age. No one should get screened under the age of 40, but 40 is probably the earliest if you're certainly in a high-risk group. We want to avoid universal screening for everybody and then potentially limit screening after the age of 75. We want to prioritize equity. Okay, so we know that there are, systemic and biologic differences, and we really want to equalize care amongst men. And then we really want to triage those patients who are likely to have a higher risk of prostate cancer, so clinically significant prostate cancer. We should triage those patients with multiparametric MRI or biparametric MRI before the biopsy. So thank you so much for your time and attention. Happy to entertain any questions from the group.
Thank you so much, Dr. Watson. That was really very informative. Wondering, are there any questions from anybody first before we go to Dr. Stern?
Marsha Jackson is asking, why are you ignoring low indicators for men? Well, for women, early detection is the key. Sean, do you want to?
Maybe I'm not understanding the question.
Yeah, I am a little also, I don't think you intended to say that you ignore low indicators for men. Marsha, do you want to clarify your question?
Yes, can you hear me now?
Yes, we
Yeah.
can.
Okay, so you kept talking about low and high indicators,
Mhm.
and you were saying that you wanted to ignore the lower and address the higher indicators, which I don't understand.
Got it. I think I understand your question now. So there are different Gleason grades, and depending on the Gleason grade, it could be a Gleason 6, which is very low risk, low grade prostate cancer. Gleason 7 is a intermediate grade prostate cancer, and this is based on the biopsy that the pathologist will look at. And then there's the high Gleason grades, the 8, 9, and 10. So we know that the Gleason 7s will behave a little bit more aggressively. They're more prone to coming outside of the prostate and going into the lymph nodes and becoming metastatic disease. The higher grades obviously behave a little bit more aggressively, but there's a lot of studies that show that the Gleason 6, the low-grade prostate cancers, really do not leave the prostate. They don't metastasize, and they're unlikely to cause death in men. And when you look at the large studies that said, hey, really screening doesn't save lives, what they have done is they've mixed the low and the intermediate and the high grade prostate cancers. And we've really done harm to men by treating those low grade prostate cancers. How do we know? Over the last 30 years or so or more, we've treated low grade prostate cancers. And we know that based on large studies that do what we call active surveillance, that you really don't need to treat patients with low-grade prostate cancer. If you do a biopsy and if you have 12 out of 12 cores of low-grade prostate cancer, that patient is unlikely to die from prostate cancer. Certainly, that's a difference from the 7s, 8s, 9s, and 10s. And so nowadays, as a specialty, urologists have moved away from treating the low-grade prostate cancers because what we do know is it causes urinary incontinence and erectile dysfunction, not to mention there are obviously other risks of radiation and surgery that can happen. And we don't want to have someone suffer the effects of prostate cancer treatment for something that really wouldn't have affected their longevity in the future. So we really do not want to find the low-grade prostate cancers. Yes, it makes sense if we find low-grade prostate cancers, won't that, you know, um, develop into an intermediate or high-grade prostate cancers. Biologically, sometimes that never happens in a large subset of men, and so we really don't want to find those prostate cancers, but find the Gleason 7, 8s, 9s. And there's large centers like the University of Toronto and Johns Hopkins where they've done active surveillance on men who have had low-grade prostate cancers, and they follow them for 15, 20 years, and a lot of those men do not need prostate cancer, and they're alive, doing well. They may die of other things. So hopefully that answers your question.
Marsha, I actually take Dr. Wason answer one step in the following direction. There is a fundamental difference between breast cancer and prostate cancer as a general proposition. Of course, it depends on family history, it depends on risk factors, it depends on age, etc., etc. But if we look at overall prostate cancer risks vis-a-vis breast cancer risk, breast cancer tends to be much more aggressive and much more dangerous, so to speak, compared to prostate cancer. And actually, there has been a very intense debate last couple of years in medical community whether or not low-grade prostate cancer described by Dr. Wason actually should be considered a benign disease. And as you can imagine, because it has a very benign clinical course, and of course, as Dr. Wason pointed out, we do not want to cause harms of treatment to something that is a benign disease, essentially clinically. Does it address your question? Did we address your question?
Yes.
Okay, very good.
Yes, you did. Thank you.
Great. We also have a question from Brian Jarvis. One of your slides showed similar infection rates between transperineal and transrectal biopsy. That may be different from what's usually reported. Sean, do you want to address that question?
Of course, that is a very great question by Brian, very astute. And just to give some background, traditionally we would do the transrectal ultrasound guided biopsy. And so that's taking an ultrasound probe, putting it into the rectum, and then taking needles that go through the rectal wall directly into the prostate. That does not seed prostate cancer, we know that. But certainly by taking the needles, putting it through the rectal wall, that can lead to post-biopsy infection, urinary tract infection, or God forbid, urinary sepsis, which obviously can be life-threatening. So two major risks of the biopsy: bleeding and infection. And we really want to obviously minimize harm, and we really want to minimize the infectious complications. All the patients undergoing a biopsy, typically we give an oral or an intramuscular injection of antibiotics to reduce the risk of post-biopsy sepsis. There's been another way to perform biopsies, and that's done transperineally. And so that's the area between, let's say, the base of the scrotum and the anus, kind of going through that particular wall, avoiding the rectum in its entirety. And you can pass a needle directly into the prostate. And so clearly over the years, there's been a lot of debate on which one is better at reducing infectious complications. I would say that the pendulum, swung from performing transrectal guided biopsies to performing transperineal, because a lot of those patients, don't need antibiotics. And, a lot of studies have shown that there's actually, reduced risk of infection if you go the transperineal route. A lot of these studies are what we call very heterogeneous. They're not they're not great studies from a research standpoint, but lately we've had some very high level research studies. So what you want is a randomized controlled trial with a large volume of men. So randomize men into getting either transrectal or transperineal biopsy. And recent large studies have really shown that between those two, there's not really a dramatic difference in infectious complications between those two groups. So, it's really muddied the waters, but the latest evidence would suggest that there's really no major difference in infectious complications between those two groups. So, we still do transrectal, we still do transperineal, we do our very best to reduce the risk of complications, but the pendulum has kind of swung back to, really considering both of those approaches as equivalent. So, great.
As you probably know, Brian, there is usually a big difference between preliminary results that were very promising and were highly publicized about perineal access to biopsy vis-a-vis transrectal access, vis-a-vis the kind of large-scale studies mentioned by Sean. And usually these studies this kind of larger scale studies take a very critical and careful look at the comparison. And as Dr. Wason pointed out, in this larger scale study, the differences in infection rates were almost comparable. The jury is still out, but that's the current opinion based on the latest data. Do you have any other questions, Brian? Okay, then we have Michael who raised his hand.
Yes, greetings. My name is Michael Gwynn, and I'm also a member of NABSW from the LA chapter. First and foremost, I'd like to thank Sister Wilson and the Boston chapter for presenting this. I was diagnosed with prostate cancer back in September. You can imagine the effect and the emotional effect, but I was actually more worried about how it would affect my daughter and my children and my family. But I have one comment or two. If you have a great urologist, you really got a good friend. Secondly, Dr. Watson, I wish I had called you. I would have flown wherever you were located to provide me with that alternate exam, because the exam I had was I mean, I survived it, but I'm tuning in to what you just shared. But my level's a Gelson 6, so you've actually reinforced what my urologist had shared, but become a what you would call a fighter or an advocate for prostate or good prostate health. But after that point, I go every 6 months. Believe it or not, the last time I checked, I had like a 4.2 level, and now it's down to 3.5. So the point I'm trying to make is I wish I would have saw a lot more men on here, but that's okay. But the reality is that it's life-changing, but it's not a death sentence. So I'd like to encourage all of those who have brothers, fathers, nephews, friends, husband, whatever. Make sure that you encourage them, just for a regular checkup. But, other than me trying to slim down and get to my high school weight, I didn't have any type of urination issues. I didn't have any issues where, my intimacy. It's just my doctor checked me out, and actually my prostate was large and, was small and hard and not fluffy like it usually is. And so if you got a great urologist, you can go through that process and a great support. And I shared it with my family in Thanksgiving. And I didn't really want anybody to feel sorry. I just say, look, I'm not putting this on the level of, I don't know, the common cold, but I'm saying, like anything else, you have to educate yourself. You have to be proactive. You have to face this like you would anything else. But I had to be on today. I just appreciate the folks that are here that are sharing the information. And then it kind of encouraged me to help those who may be in the dark, or those that may not really have a true understanding of what this is and how it can affect all concerned. So thank you again.
Thank you, Michael, for sharing your story. Very touching. In the chat, I'm going to put a book. It's the author is Mark Moyad. He's a researcher at the University of Michigan, and he has a couple books out there. But one of them is really Nutrition for Men with Prostate Cancer. And I would encourage everybody who has a family member who has prostate cancer to kind of share this book. I have a lot of men like yourself who were diagnosed, fortunately, with low risk or very low risk prostate cancer. And they ask, what is it that I can do moving forward? Number one, we always recommend any diet that's sort of heart healthy is obviously good for the prostate as well. Weight loss, consider medications like metformin on reducing your risk of prostate cancer. And I think that, there can obviously be a lot of stress and anxiety being diagnosed with prostate cancer. And really our role as a urologist is to really, set expectations for, men and really try to say, hey, this is going to be a chronic disease that you're going to live with, like hypertension, high blood pressure, or diabetes. We can manage this. This is not going to be a threat to your health, but certainly does require ongoing dialogue between you, your family doctor, and family.
Thank you very much, Sean. We have one more question. I may have missed it, but why are Black men more at risk of prostate cancer?
You want to answer that, Faye?
Actually, I would ask you to address this question.
Yeah, I would say that clearly there are social issues at play. I think that just with history with some experimental studies in the past, I think that there is a lot of mistrust in the medical system, amongst Black men, Black women as well. And I think that there's if we look at all the research studies that talk about prostate cancer, Black men are really only a small subset of patients enrolled in clinical trials, whether or not that's willing to participate or willing to get Black men involved in clinical trials. There are obviously some biologic markers out there that make Black men at higher risk of prostate cancer. I don't think that it's very, very well defined, but clearly there are a mixture of some biologic risks and traits, as well as social risks as well. And so it's a complex, and I don't think it's easily answered. I think that there's a lot of smart researchers out there trying to study the differences. I think all we can just say is it does look like there are differences, but obviously these differences can be equalized if everyone's sort of treated the same. Everyone gets access to a primary care doctor, which is going to obviously be challenging in some areas. Make sure everyone gets access to a PCP, blood test, and MRI, and so we can level the playing field. Clearly, there are some things out of our control. But I don't think that we have, a clear answer as to, all the differences between, Black men and other ethnicities.
There has been a fascinating study that came out about 1 year ago from Cornell and Columbia, and they actually demonstrated distinct differences in genetic composition of prostate cancer in Black men vis-a-vis white men. And yet, if we look at the multitude of data we have, Mr. Shinaka, what we see is that it is overwhelming to what extent access to care outweighs biological differences in Black men. For example, in military medicine, in veteran administration, they demonstrated with equal access to care, there are no differences. for example, in mortality between Black and white men. And this is independent of the level of income or level of education. There is just such an incredible amount of data coming from military and VA medicine. And the latest consensus of NCCN mentioned by National Comprehensive Cancer Network, mentioned by Sean Wason, that our organization is aligned with the most. It consists of leading world experts in prostate cancer research and clinical care, and they reached unequivocally consensus that access to care outweighs any difference in biology of prostate cancer between Black and white men. Any other questions for Dr.
Well, I
Wason?
must say, I just want to say that this has been so far already a phenomenal engagement, right? In terms of our brothers and sisters across the country who are tuning in to this dynamic conversation, and our brother who just shared his own personal story, and those who are sharing in the chat. So, thank you for doing that, as well as, Dr. Watson, just thank you for being such good, good in your craft in terms of knowing what you're talking about and being able to share and deliver in this space. Are there any other questions before we turn over to Dr. Stern? Brian, go ahead, please.
Yes, it's probably easier to speak than it is to type in the chat. The doctor didn't go over active surveillance. I was on active surveillance for 9 years, from 2012 to 2021, and that bought me time to research all these things that you're talking about, so that when I did choose treatment, I'd be more informed to make that decision as an informed patient. Could you go over active surveillance for the group?
Sure thing, Brian. So active surveillance is something that we do if we diagnose somebody with a low-grade prostate cancer. So there's really 5 risk categories. There's very low risk, intermediate, high, and very high risk prostate cancer. So really 1 to 5. And active surveillance is done for the men that really have the Gleason 6 disease, or you could have a low volume Gleason 7 disease and maybe be a little bit older with not as much great health. And so if we think that you have competing comorbidities, if you have other reasons where you may not want to treat prostate cancer, we can put those patients on what we call active surveillance. So we're not forgetting about you. We understand, hey, you have prostate cancer, you have a diagnosis of prostate cancer, but we certainly need to monitor the disease progression. So in my practice, if someone's diagnosed with prostate cancer, I give them all the information. You can have surgery, you can have radiation, you can have HIFU, high intensity focused ultrasound, or we can consider active surveillance. For the patients with the Gleason 6 disease, I may say, okay, I think you're an excellent candidate for active surveillance. I know this is very anxious to you. How we're going to monitor this is, every 6 months, we're going to do a PSA. We'll monitor your PSA. You do want to wait a period of time after, your most recent biopsy to get that secondary PSA. So at 6 months, you'll do a PSA. Within that year, or shortly after about 12 months, you do need a repeat biopsy. So anyone that I'm considering active surveillance on, at 6 months, I do a PSA, make sure it hasn't gone up too significantly. At about 9 months, I'll repeat the PSA, but I'll also consider repeat imaging. If you don't have a lesion noted on the MRI, those patients, you can obviate the need for a second MRI sometimes. But at around 9 months or 12 months or shortly thereafter, that patient will get another biopsy. So you're really getting 2 biopsies within a year. Super uncomfortable. But the good news is, if you don't have any disease progression, if you still have Gleason 6 disease, and sometimes we do a repeat biopsy and we don't find any prostate cancer. It's not that we missed it the second time around. Maybe it was just so small and low, so grade that this is not a worry. So if those patients have a repeat biopsy, they're still Gleason 6. Those are excellent candidates for continuing active surveillance, and that involves a digital rectal exam at a year, PSAs at usually Q6 month intervals. We'll check your vitamin D and other levels. And usually we kind of space out the biopsies. We don't want to do too many biopsies, too often, but, the next time, could be another 2 or 3 years down the road. And I usually base that depending on the PSA kinetics or if there's been a change in the MRI. So that's active surveillance in a nutshell. Again, these centers like the University of Toronto, they've been doing active surveillance on men for 20 years, and they do have a large cohort of men that they're still on active surveillance 15 years later. They have not needed any treatment for prostate cancer, and they're doing well and they're healthy, and they haven't suffered the ill effects of surgery or radiation. Certainly, there are some patients who you may, and I see it in my practice, you may biopsy them at a year. Okay, you found a couple more slivers of an intermediate grade prostate cancer. Not a great person to continue on active surveillance. At that time, you pull the trigger. You probably haven't lost much by waiting that year, and you're really focusing on the patients that really need the prostate cancer treatment. So certainly active surveillance is a very good option for a subset of men that don't have any intermediate or higher grade disease. Hopefully that answers your question.
Yes, thank you.
Awesome. Thank you so much. All right. We are going to move on to Dr. Stern. Dr. Stern, you have a presentation for us?
Absolutely.
Oh, and I'm sorry, before we do that, I also want to welcome our president of the Greater Boston Association of Black Social Workers, Jasmine Welcome, is on the call. So thank you so much, President Welcome, for joining us, along with our many members as well. Thank you.
Aisha, everyone, thank you so much for the opportunity to present prostate cancer information. It's important for us, and it is our mission. I prepared my presentation, and I usually prefer to do pre-recorded videos to avoid technical problems. Emily, do you mind?
My name is Faina Stern. I'm a physician and president of the AdMeTech Foundation, a nonprofit organization leading regional, national, and global programs in prostate cancer education, research, public awareness, advocacy, and clinical care equity. I'd like to thank Aisha Wilson and Greater Boston Association of Black Social Workers for partnering with AdMeTech in presenting this prostate cancer awareness event. In my talk, I'll describe AdMeTech Foundation's history and our prostate cancer program, established to lead cutting-edge advances in patient care and eliminate health disparities. In particular, the focus of my talk is on the AdMeTech Foundation Prostate Cancer Equity Resource Project, created to ensure that all Massachusetts men have access to high-quality care, including the best-in-class advances in screening, diagnosis, and treatment available today. History of AdMeTech Foundation and its programs is closely tied with my own professional and personal history. Since 1990, I was head of diagnostic imaging research branch at the National Cancer Institute. In this position, I was leading development of national and international research policy and related strategy and programs for the National Institutes of Health, Department of Health and Human Services, and U.S. federal government. Our priority focus was on the advancement of breast cancer imaging. We created digital mammography, breast MRI, advanced ultrasound, and molecular imaging for improved patient care. We also worked on teleradiology for image transmission for a second opinion, so that we could bring world-class expertise to underserved, rural, and remote communities. These breast cancer programs led to transforming screening, early detection, and treatment of breast cancer and reducing health disparities. Precision imaging made it possible to improve screening and accurate diagnosis, critical for early detection and saving lives for all women. to create minimally invasive lumpectomy when we identify and remove only a part of the breast tissue containing tumor. This minimally invasive lumpectomy replaced radical surgery such as mastectomy when the entire breast and surrounding tissues are removed. Lumpectomy is performed in outpatient clinics with minimal complications, pain, suffering, and costs. Precision imaging and early detection also made it possible to reduce health disparities in Black women. In 1996, while our breast cancer programs were well underway at NIH, I brought together the key leaders of government, medicine, and industry who recommended prostate cancer as the next national priority focus for several reasons. First, prostate cancer is the most common major internal cancer among men. It is as common among men as breast cancer in women. Prostate cancer strikes 1 in 8 men, while breast cancer strikes 1 in 8 women. And yet, prostate cancer diagnostics and care lagged behind breast cancer by several decades. Second, prostate cancer screening with blood test PSA was successful in identifying men at risk of losing their lives and in reducing mortality or death from prostate cancer. However, men needed accurate diagnostic tools that would make it possible to sort out if abnormal screening result was due to false alarm or due to a life-threatening prostate cancer. Accurate diagnostic tools would make it possible to create personalized and most effective plan for clinical care for each man and avoid unnecessary procedures. Third, treatment of prostate cancer, such as radical surgery, was highly invasive and traumatic, leading to prolonged hospitalization, difficult recovery, and unacceptable level of life-altering complications. Similarly to women with breast cancer, accurate imaging would make it possible to develop minimally invasive treatment for men with prostate cancer or male lumpectomy. Fourth, prostate cancer is a leading health disparity. Black men are 2.5 times more likely to die compared to white men. We did not see this level of disparities in breast cancer even early in my career, in the 80s and 90s. Finally, in sharp contrast to women with breast cancer, men did not have accurate imaging, leading to blind biopsies and treatment. Our work in breast cancer imaging created a blueprint for transforming prostate cancer care. At about the same time in 1996, I had a personal experience that left me rather shocked. A leading clinical expert in Massachusetts, chosen by me, examined my father and determined that he had a benign and common prostate condition. However, when my dad had an invasive procedure, he was found to have prostate cancer. It was stunning to me that the leading expert in a world-leading hospital did not have the appropriate tools to make accurate clinical diagnosis. This experience transformed my professional interest in prostate cancer into a personal mission to improve early detection and treatment of prostate cancer for all men and to reduce health disparities in Black men. If we made a difference for women with breast cancer, we could make a difference for men with prostate cancer. I mobilized other leaders of medicine, and we approached National Cancer Institute and NIH in the hope to see an increased government investment in prostate cancer research. Unfortunately, in spite of our joint track records and a year-long effort, we did not succeed in convincing U.S. government. In response to the lack of support from federal government, by late 1997, we established AdMeTech Foundation with the mission to end blind patient care and create the future of image-guided, minimally invasive diagnosis and treatment. We call it the Manogram Project. Since 1997, we have been leading pioneering research that resulted in creating and clinical implementation of precision MRI, molecular imaging, robotics for biopsy and treatment, and other precision diagnostics and therapeutics that transformed prostate cancer care. In 2005, we initiated a large-scale national public awareness campaign, where is Manogram, prostate imaging for men. In 2009, we had the first annual Prostate Cancer Awareness Day in Massachusetts State House and proceeded to create a new model in public education. In 2011, as the result of our advocacy, Massachusetts legislature had set up a historic precedent by recognizing prostate cancer as the central healthcare problem in men, a leading health disparity and public health priority. In 2013, Massachusetts legislature established a prostate cancer program. It started as a research project that was seminal in making MRI a new standard in patient care for guiding biopsies and treatment. So in 2014, we expanded our efforts in public awareness, reaching countless people. In 2016, we established annual global summit on precision diagnosis and treatment of prostate cancer, which, unlike other medical educational events, brought together leaders of all medical subspecialties involved in patient care, took down interdisciplinary silos, and became instrumental in creating a broad international consensus on the best clinical practices and research priorities. In 2021, we have launched Prostate Cancer Equity Resource Project to make sure that all Massachusetts men had access to the best care available today. And in 2023, we created an international working group in minimally invasive treatment to expedite clinical testing and implementation of male lumpectomy. Our statewide program in prostate cancer created a Massachusetts model of national and global leadership in public awareness, medical education, research, and health equity. AdMeTech is leading prostate cancer program in cooperation with multiple organizations, including American Cancer Society, leading state clinical experts, and multiple branches of the NAACP and Latino Health Insurance Program located across the state. Our primary focus is on high-risk men, Black, Hispanic, and Latino individuals, and all men with family history of prostate cancer and increasing age, 50 and older. Our public awareness has focused on the importance of screening and early detection, critical for saving lives. Since 2019, we reached well over 71,000 people. The centerpiece of AdMeTech's medical education is annual global summit on precision diagnosis and treatment of prostate cancer. Our summit has been recognized as a seminal event in shaping the state of the art and future vision for patient care. Our summit brings together the key international experts representing every clinical field to review the best emerging clinical practices and research needs and priorities. There is not a corner of the world that has not been represented at this event. The latest 9th annual conference took place only in September 2025, several weeks ago. Our summit demonstrated that early detection saves lives and eliminates health disparities. With early detection of prostate cancer, every man is alive in 5 years. In sharp contrast with late diagnosis, when cancer is spread outside of the prostate to other organs. Only 28% of men remain alive at the same time. Early detection is particularly important for high-risk individuals, including any men with family history of prostate cancer or Black men who are twice as likely to die as white men. In prostate cancer, screening with blood test called PSA is the best tool we have for prevention and early detection, critical for saving lives and reducing health disparities. If we look at the reduction of mortality per year, PSA blood test is the most successful screening tool we have had in the history of cancer. It is important for men to take charge of prostate health. To do that, it's important to know your risk factors, such as Black heritage, family history of prostate cancer, particularly when your brother or father had this disease, and increasing age, 50 and older. You can assure early detection during annual visit. Ask your doctor to discuss if PSA blood test and digital rectal exam are right for you. You need to talk to your doctor starting at the age of 40 if you have risk factors I just described, or at the age of 45 if you do not have these risk factors. Before screening, it is important to avoid exercise or sex, which may impact your testing results for at least 2 days. After screening, you need to ask your doctor if your test is normal or if you need to see a prostate cancer expert for further evaluation. Our summit concluded that equal access to high-quality care is the key factor in improving patient outcomes for all men and eliminating health disparities in Black men. It is particularly important now with so many novel diagnostic and therapeutic approaches, ensuring high-quality, personalized patient care. Without equal access to these advances in patient care, we will see a widening gap in health inequalities, including survival and mortality. Consequently, AdMeTech launched the Prostate Cancer Equity Resource Project in Massachusetts in collaboration with Mass General Brigham, UMass, and other clinical institutions, with the mission to save lives and deliver high-quality care for all. More recently, experts from Beth Israel Lahey joined us. Supporting organizations include Latino Health Insurance Program and multiple NACP branches located across the state. Any Massachusetts man age 40 and older is welcome to participate. Our priority focus is on Black, Hispanic, and Latino men who are at high risk of prostate cancer, delayed diagnosis, poor quality care, and death. Our goal is to expedite access to leading experts who use the most advanced approaches to screening, diagnosis, and treatment available today, and to support men every step of their medical journey. This program helps men to find an expert for the initial or a second opinion in person or virtual visits. We believe that in Massachusetts, with its leading hospitals and universal access to care, our prostate cancer equity program will be able to eliminate health disparities. Experts of the prostate cancer equity program can address any questions about prostate health, from assessing an individual healthy man's personal risk of cancer longer term, to informing men about all available options before and after screening, biopsies, and treatment. We are committed to supporting men during every step of their medical journey to ensure that no man is left behind or struggling alone. To achieve this goal, we created a streamlined process of patient referral and care, reflecting how doctors involved in this program would like to take care of our families and friends. This process consists of several components. First, AdMeTech Foundation's team collects basic information and match individual patients' needs with the appropriate state's experts for clinical care. Second, a clinical organization designates a patient navigator to expedite a medical visit and related needs, including scheduling, registration, transportation, financial and insurance assistance if needed. Third, if an expert recommends any next steps, AdMeTech's team and patient navigator work with men on the appropriate follow-up, such as, for example, additional testing or treatment. I'd like to provide a few recent examples of how PCE Resource Project has been making a difference. In December 2024, Martha's Vineyard NAACP asked us to help an older Black man who expressed a lot of confusion and concerns about his care. AdMeTech staff contacted Dr. David Einstein at Beth Israel Lahey, who agreed to provide a second opinion. In February 2025, this man and his wife had a visit with Dr. Einstein, who provided a clinical consultation and contacted the regional clinical care team to ensure a coordinated approach. In March 2025, this man and his wife described that as a direct result of Dr. Einstein's consultation, they understood their situation for the first time and became clear about the next steps. The second example involves George Brickhouse, who in December 2022 took part in the virtual meeting of the PCE resource organized by Steve Burnett, immediate past president of Brockton NAACP. During that meeting, George expressed the lack of trust in his care and difficulties in scheduling prostate MRI recommended by his doctor. We got concerned, and after the meeting contacted Steve and asked him to explore with George if he would be interested in our PCE resource. In early 2023, George contacted us and we suggested for him to consult with Dr. Kwok-Ding Trink of Mass General Brigham, who can ensure the best of last care, including high-quality MRI. George has been so happy with his care that he became an advocate for our prostate cancer equity resource. In late 2024, Dr. Trink moved to Pennsylvania due to academic promotion. In March 2025, per George's request, we referred him to Dr. Adam Feldman, another leading clinical expert at Mass General Brigham and our partner at that clinical institution. Emma Coyer serves as a manager of the Prostate Cancer Equity Program. Emma is assisted by Erin Roberts, program coordinator, Craig McClay, patient educator, and other members of the AdMeTech Foundation's team. We serve as your individual patient care advocates. When you come to us, Emma will work with you, our team, Mass General Brigham, UMass, Beth Israel, and other clinical partners to expedite medical visits and address any needs you may have. Together with clinical experts, we empower each man to make informed choices in patient care that are right for him before and after screening, biopsy, and treatment. If you have any questions or need assistance, please contact Emma by phone 617-523-3535 or by email coordinator@admetechfoundation.org. Thank you for your attention. Any questions for me about AdMeTech Foundation or about our prostate cancer equity resource project?
I have a question.
One moment.
So-
Yes, Marcia?
Yeah, so how is it people are referred to you? Is it as a result of seeing the presentation or through their primary care doctor or community resource?
Great question.
Marsha, AdMeTech Foundation has built a very extensive partnership with NACP branches, with Latino health insurance branches, with multiple organizations across the state. And a great majority, we didn't just build relationship over the last more than 10 years. We built trust. And most referrals we get is actually from our friends in NAACP and Latino Health Insurance Program and other community organizations. And it's very important to us because it sets the stage for something that is critical in patient care, particularly of minority men. For example, if we look at the statewide data, Black men are 22% less likely to comply with physicians' recommendation to have life-saving treatment compared to white men. This is unacceptable. Even greater percentage of Black men do not comply with physicians' recommendation to have biopsy for definitive treatment. This data indicate a fundamental lack of trust, fundamental breakdown in relationship between physicians and Black men. Because we have referrals from community leaders primarily, if AdMeTech staff or clinical navigators at clinical institutions believe that man stopped communicating because he got scared or whatever clinical recommendation he had, or he's at risk for being close to follow-up, we contact community leaders who we know, and then we essentially ask them to talk to this man and to support them so that together we'll get this man back on track for appropriate diagnostic procedures such as biopsies, for example, or treatment. So this is very important to us. Most people, this program served over 120 men since its establishment a couple of years ago. However, these were mostly men who did not have insurance, who had insufficient insurance. So we had to work with our clinical partners to make sure that we use whatever resources available in the state to help men, whether or not it is insurance, whether or not it is scheduling, whether or not it is financial assistance, transportation assistance, etc., etc. Let alone scheduling. I think all of us know what it is like to call busy physicians' offices and to deal with schedulers who it's usually a very impersonal experience. So the men who come to our program do not deal with registration departments, with financial assistance and whatnot, transportation assistance. They have a chance to build trust with AdMeTech staff, with somebody like Emma who is managing this program, or clinical navigator at a clinical partner institution. So it is not just a referral, Masha. It's not just where men are coming from. It is creating infrastructure of support that men will get the best care available, and we will not lose this man to follow up. Does it address your question?
It does, but you also raised a really important issue. Oftentimes, men and Black women don't want to go to these health appointments for tests because they don't have the insurance. And given that a lot of people have lost, and there are cutbacks on insurance, how will AdTech, help them cope with that?
That's a great question. Unfortunately, we cannot create miracles. We can use the best resources available in the state and at the federal level. But and thank God, Mass Health covers men, for example, with green card and with green cards and citizens. Unfortunately, unless the state and federal authorities resolve the issue, for example, how to deal with on proactive basis with, let's say, people who do not have green cards, we will not be able to help them. But as long as men have green cards, as long as men are citizens, we can help them. For example, there was a couple of men who came to us who did not have sufficient insurance to see some of the leading experts we have. So we contacted National Cancer Institute, Dr. Peter Pinto, one of the long-term collaborators of our organization, one of the world-leading experts, and NCI, as a federal institution, can get any citizen in Bethesda, Maryland, into clinical care without any charge at all, and they will also cover travel. So once again, we are a relatively small organization. We cannot resolve issues that have not been resolved by the state and federal authorities. But in our experience, not many men, particularly in Black community, know full resources available at the state and at the federal level.
Thank you. Very important information.
Any other questions?
Hey, Marsha, I just want to add that I did put some information that you had chatted me and I chatted you back with some information as well.
And we have Emily here, Emily Mao, who is a member of our team, and she will put in the chat information how to contact us, our phone number and email, contact@admetechfoundation.org. As long as you will call us or contact us by email, if you need assistance, if second opinion, initial opinion, for any man who is making a decision whether or not screening is right for him, whether or not biopsy is right for him, whether or not treatment is right for him. We are very clear that there is a number of social workers here. We are very clear what a close relationship social workers develop with patients. If any of you believe we can help your family members, your friends, or your patients, we'll be happy to do so.
Thank you so much. Again, I don't see any questions. However, this has been an amazing and robust conversation. The partnership between Greater Boston Association of Black Social Workers and AdMeTech really came from my affiliation with working not only as a facilitator and contractor with AdMeTech, but also through my partnership, relationship, and trust building with AdMeTech through my work with the NAACP Cambridge branch. It has been an honor to serve as your moderator or MC tonight. I'm also very grateful again to the Community Affairs Committee and the Education Committee of Greater Boston Association Black Social Workers, as well as our Communications Committee for making sure that we got information out and made sure that you all are here with us in this space. Again, this has been very robust. We are truly grateful, and we want to continue the conversation because, as we heard already, Black men are at greater risk of being diagnosed and even passing from prostate cancer if they are going undetected or if they are not getting treated and supported early enough. So please get tested. If you are a man over the age of 40 years old, this isn't just a black or white issue. This is an all man issue, but it also, again, as we talked about at the top of our conversation, the impact on the loved ones. right? And as social workers, we're oftentimes seeing not only just the patients, but the loved ones of those patients. And we are there to provide care and be empathetic and supportive to those needs as well. And we know that the partnership with AdMeTech will allow us to really reach out to even more and more men across the board. So again, we are grateful. Information is in the chat. We look forward to continuing the conversation. Please get checked and tested. And if you are the loved one of someone who is over the age of 40, please encourage them to get the test that they need. Dr. Watson or Dr. Stern, do you have anything that you want to add before we close out?
You're an amazing multitasker.
Story of my life.
Yeah.
I think you hit the nail on the head. Get tested. It's easy to do, and there's a lot of support systems available, especially for men in Massachusetts. I think we're very fortunate, and you have a lot of great institutions, and there really should be no one left behind.
And I agree with Sean. The only message I want to leave everyone with is screening, early detection can save life. And AdMeTech Foundation has a clinical prostate cancer equity resource who can get men to the best physicians in the state, including Dr. Basin.
Thank you. Ms. Cheryl, you have a question?
I have a question or say a comment. Thank you very much. It's very informative. But one of the things that, we have to emphasize with all as social workers, as people of the community, whatever it is, we've got to talk to each other. And there are so many people, including my own family, which is very large, spread out all over the country, but large. We don't talk about stuff like this. We don't. It's there. If someone happens to know that you had a problem with it and you had, treatment or whatever, but generally we tend to find out about it at the funerals. And I hate to say that. So I think that if we can encourage people not only to get tested, but just to talk about it. And as we were promoting this workshop last week, I went to people that I'd never met before, never seen. I didn't know who those people were, but they were there. I said, well, look at, take the QR code and come and, get some information. Just hear what people are saying, because we don't talk about this. And we definitely have to encourage people to do that. But thank you so much. It's very informative.
Thank you so much, Ms. Cheryl. And I think to that point, and I think Dr. Watson said this clearly at the very beginning, is that that's probably also what helps to amplify why that number is so great within the Black and Brown community, right? Is because oftentimes folks are not going to get tested and getting the treatment that they deserve. And the earlier you are able to get tested, right, the treatment is able to kick in, and you are, able to do the hopefully right things in order to have longevity in life. And that is really important. So, I'm just, again, grateful for this conversation, grateful for having such a robust audience. Ms. Lucinda?
Sure. I also want to echo, thank you both for the presentation. I think I myself, as I was sitting here, was trying to go through my own, my dad's records, just to see what information I remember from what the doctor told me and what I'm hearing. And I learned so much more just from hearing the presentation. And I think even having other family members that I know where they were diagnosed, but it's very hush hush. We don't talk about that, kind of like what people are saying. It's almost that kind of like shame, or hey, it's only happening to me. It's not everybody, and we don't talk about that. And I think that more presentations like this is needed so we get the education. And I know I learned a lot. So thank you.
Thank you. And again, as chair of the Education Committee, co-chair, thank you again for your promotion, for your partnership, and making sure that this is such a robust space and conversation for our community. Again, as we hit that 8 o'clock hour, we are really, again, grateful for all of you who have joined us today, to Dr. Stern for the vision and the work around AdMeTech Foundation, to your staff, to Dr. Watson for your partnership and your work, your knowledge, and your skill. Please, thank you so much for your work. Thank you for your continued partnership. And everyone, please have a good night.
Thank you so much.